満席に近くなっておりますが、空いているお席の方、
If there are still some seat available, so please don't hesitate to find a seat. And this is the Wi-Fi ID, SSID for free Wi-Fi. So if you wish to connect your devices with the Wi-Fi, this is the SSID.
まもなく開始させていただきますが、この会議は同時通
We would like to begin shortly, and this will be done through simultaneous interpreting, and the receiver is on your desk. And the simultaneous interpreting device, channel 1 is Japanese and channel 2 is English.
まもなく開始いたしますが、この
We would like to begin shortly, and this will be done through simultaneous interpreting, and the receiver is on your desk. The simultaneous interpreting receiver, channel 1 is Japanese, and channel 2 is English. In the Sky Studio, there is a live video. That is why you can also view from that venue.
皆様、本日はお忙しい
Thank you very much for taking time out from your very busy schedule to attend the first day of a Global Dementia Legacy event in Japan for the first day of sub-specialty workshop. My name is Yumi Kameyama. I'm from Department of Geriatric Medicine of the University of Tokyo Hospital. Now, to open this specialty meeting, we would like to ask the Dr. Koji Miura of Director General of Health and Welfare Bureau of the Elderly Ministry of Health, Labor and Welfare in Japan to give us an opening address. Good morning, ladies and gentlemen. Thank you very much for your kind introduction. I am a Director General of Health and Welfare Bureau for the Elderly Ministry of Health, Labor and Welfare in Japan. Today, we have experts from government and also the medical the field, and also the people with the dementia and also family of the people with dementia to attend this the meeting. Thank you very much for coming. Now, I am very honored to be able to hold a Global Dementia Legacy event in Japan, and also I'd like to thank all of the pertinent people and organizer to be able to for us to be able to have this event in Japan. In Japan, it says that 25% of the people are people with dementia or the borderline people with the dementia. And with the aging society, we expect the number will increase from 1 out of 4 to more. Now, it is very important to realize a society for the people with dementia to be able to live in a community that they are used to. And G8, out of G8 nations, that Japan is entering the aging society much rapidly than other countries. So it is a very good, important point for Japan. Last year in London, we had a G8 Dementia Summit, and that summit, they renewed our commitment to tackle this the problem issue of dementia with the global nations hand in hand. There, we understand and identified issues of the dementia, and we had a declaration, and also U.S., the Canada, France, and Japan and Germany that we will have the legacy event. And also we established the global dementia meeting. This is the legacy event held in Japan. And Japan, again, is the country who is going into the super aging society. And we have an important theme, which is Japan-led, which is new care and prevention models. As a Ministry of health as and also from the Japanese government, we think it is extremely valuable to share expert knowledge at the specialty meeting and for today and also tomorrow. We are looking forward to hearing from all of you and sharing the information, sharing the knowledge, so that we, each and one of us, have some take-home messages. Now, I am a Director General of Health and Welfare Bureau of the Elderly, and I am in charge of putting the policy together for elderly people. And personally speaking, 15 years ago, we Japan have the care insurance, which is the public, and the people older than 40 need to pay the insurance for the care insurance. And I was 15 years ago, I was involved in establishing this system. People have a very big fear of dementia. And people have the stereotype idea that once one becomes the person with the dementia, one has to go to the institution or facilities or elderly homes, and one cannot stay at home. But after the introduction of the home care system, after more than 15 years, the Japanese public start to understand more about the people with dementia. However, still, we are at the entrance gate for the understanding of the people with the dementia. Now, I feel fate of becoming the person in charge of the topic, and I feel a strong mission about this, providing good health and welfare for the people with the dementia. To conclude my remark, I hope that the meeting will help all of us understand about the people with dementia better. And I hope that this international summit will help people with dementia and also family with the people with dementia to have better lives. Thank you very much.
三浦局長、ありがとうございます。
Thank you, Mr. Miura. And next, from the sponsor side, National Center for Geriatrics and Gerontology, President Dr. Kenji Toba will offer a welcoming remark.
Good morning. Welcome to Japan, everybody. I deeply appreciate your participation to this event. We have to share the crisis of the big wave of dementia. Fortunately, long-term care insurance prepared for rapid population aging is working so far in Japan. However, the increase in dementia is expected to be more than 3 million in coming 10 years in Japan. Both creating a new medicine for dementia and preparing better care system is extremely essential, important for us. Thus, it is a global chance for us to overcome the crisis for our future. So in Japanese, 認知症の予防とケアについて本邦の優れた点を世界にアピールし、同時に参加各国から学ぶ良い機会です。これらが融合した知恵によって地球規模の課題である認知症に取り組んでいきましょう。最後に、ご多忙中にもかかわらず本イベントに参加していただいた関係者の皆様、またこの準備に奔走された関係者の皆様に心より御礼を申し上げて私のご挨拶といたします。Thank you again for joining this event.
鳥羽総長、ありがとうございます。
Thank you, Dr. Toba. Next, World Dementia Council member Dr. Kiyoshi Kuroka will offer a welcoming remark.
こんにちは。On behalf of the World Dementia Council, I welcome you all to this Global Dementia Legacy event in Japan. The World Dementia Council was one of the main commitments made at the G8 Summit, the Dementia Summit last December, by the government of the United Kingdom, led by Honorable Prime Minister David Cameron. Why at the G8 summit? We enjoy better health and longer life owing to remarkable progresses in science, technology, and effective public health policies on calorie intake, hygiene, sanitation and vaccination, and many innovative drugs and medical technologies. And we have achieved more than 20 to 30 and 40 years of additional life expectancy in many countries over the many decades in 20th century. 100 years ago, for example, a life expectancy at birth was about 40 to 45 years in most advanced countries at that time, US, UK, and also Japan, and many other countries. But we gained many additional years during the last several decades of the last century. In fact, in Japan, it reached 60 years at year 1950, and now we enjoy one of the best in the world, average life expectancy of 84 years, and 82 for men, and 87 for women. With aging population, of course, unfortunately, there are many more and more individuals with decreasing brain function as a part of the aging process by an entity called dementia, about half of which is a disease entity called Alzheimer's disease. Dementia is a major health challenge in developed and developing economies. Thus, dementia has entered the file as a critical disease and social challenge, demanding more and more human and financial resources with uncertain economic prospects. The World Dementia Council aims to stimulate innovation, development, and commercialization of life-enhancing drugs, treatments, and care for people with dementia or those at risk of dementia within a generation. The Council has currently 18 members, chaired by Envoy Dr. Dennis Gillings, and I was invited to join this council. Dr. Gillings, unfortunately, cannot join this event in Japan. Thus, I am privileged to make a welcome remark on behalf of Dr. Gillings and the entire council. The World Dementia Council met first in London this April, followed by two meetings, one in Paris in July, and again in London in October. The legacy events like this were held in London in June and Ottawa in September, and now in Tokyo. The Council addresses various critical issues and focuses on, at the moment, one, integrated development that is optimizing the path of medicines from research through to market by reducing barriers and encouraging regulatory flexibility. Second, finance and incentives, thus looking to increase investment in dementia research and drug development. Third, open science and big data. Thus, information can be shared more widely throughout the world, and there is a collective global effort to find a cure. In addition, the Council considered the growing body of evidence on the link between lifestyle risk factors and dementia, quality of care of the patients and of caregivers, models of community engagement, frontiers of biomedical science, digital technology such as social robots, and various leadership by private sectors. The Council is looking forward to learning and sharing the experience of Japan, the frontier of many aged nations, where 1 in every 4 is older than 65, and more than 50,000 centenarians, and a nation which achieved the best health outcomes by WHO measurement during the last decade of the 20th century. With luck and a bit of good nutrition, each of us here in this auditorium will have the joy of passing the age of 65 and becoming an older person. And some already have, including myself. It is through cross-national exchange and collaborative meetings such as this legacy event that successful models are shared and new ideas are born as we all work together to improve the lives of older persons around the world. Thank you and welcome.
黒川先生、ありがとうございます。
Thank you very much, Dr. Kurokawa. Now we would like to move on to the receiving the speech by our guest, the President of Japan Medical Association, Dr. Yoshitake Yokokura, please.
Ladies and gentlemen, I would like to speak Japanese only. Please take your earphone or receivers.
Today, to open a Global Dementia Legacy event in Japan, on behalf of Japan Medical Association, I am very honored to give you a few words. As you know, that Japan is making a head start to move to the so-called super aging society, and therefore the world is paying attention to how we respond. The people with the dementia, the number of the people with dementia is increasing, and therefore how Japan will respond to that, and what kind of policy to support people with dementia, and how Japan is building society around that is the topic that not only G8 nations but nations all over the world are paying attention to. Now, as a major pillar of social welfare policy, the establishment of comprehensive community care is underway. To build a community, provide a good system for the people to access medicine and care, and maximally exploit the self-support and mutual support in community is important so that people with dementia can be watched over by the entire community, and they don't have to leave the community and still continually live in the environment that they're used to. Last December in London, in the UK, as a part of the declaration of G8 Dementia Summit, it was declared to develop cross-sector partnership and innovation, focusing on new care and prevention models, which is the topic of today, and that is identified as Japan-led. So I have a high expectation for your future effort, and also as Japan Medical Association, we're willing to provide the necessary cooperation to conclude. I wish you all of health in the future, and also I would like to provide a deep respect for your effort by the pertinent people, and I wish that this event is a success, a full event to bring us a fruitful result. Thank you very much.
横倉先生、本日
Thank you very much, Dr. Yokokura, for coming to join us today. I would like to invite from WHO, World Health Organization. With us is Dr. Shekhar Saxena.
All of you, Director General Miura, other high-ranking officials of Japan, Ministry of Health, Labor and Welfare, distinguished delegates from other countries and other organizations, ladies and gentlemen. On behalf of the World Health Organization, I would like to thank the government of Japan for hosting this legacy event on dementia. But also, I would like to thank them for deciding to focus on a theme that is very important for WHO. New care and prevention models are central to what we believe needs to be done now. It's about care today and cure tomorrow. So within that perspective, this particular theme is of major importance for us. I come here representing the Director General of WHO, and I come here with my colleague, Dr. Yasuyuki Sahara, who knows Japan very well. And we are here to listen and learn. We want to see what the experience and the evidence is and how we can apply it in G7 countries, but much more all over the world, for many other countries which are either facing the problem of dementia now, or we are sure they will face it in the coming months and years, much larger than what they realize right now. And within that perspective, we will be hosting another event in Geneva in March 2015, and I'd like to extend a warm welcome to all of you to attend, where we hope to increase the awareness and knowledge about dementia to all the countries, G7, OECD, but then the whole world. Thank you very much, and I'm here to, again, as I said, listen and learn. Thank you.
Thank you very much, Dr. Saxena. ご挨拶の最後は
Last but not least, we have the journalist, Mr. Tomofumi Yamamoto, to offer the remark. And as is indicated in the speaker biography day 1, he was diagnosed as having MCI, or mild cognitive impairment, this year. Good morning, ladies and gentlemen. My name is Tomofumi Yamamoto. This is Shukan Asahi, in which I am a reporter. Last year, in December, I was diagnosed as having MCI, or mild cognitive impairment, which required an early intervention, early treatment. I'm a patient myself. So this time I was contacted by the event organizer to make a presentation as a patient of MCI. I thought that it would be too high an honor for me. However, I thought that I hoped that it would be of some help to you. That was why I decided to stand on the podium. I looked very young when I was young, but I'm already 62 years old, though I do not look like that. At the age of 60, I retired from the organization, and I'm now a part-time reporter, or a contracted worker. And first I remembered that I'm very much forgetful, and I thought that it was due to my age. But I was a reporter, so I had to interview people, and during the interview I take notes. However, I couldn't think of any Chinese characters to take notes, so I was not able to take notes, and I go visit my interviewees, but I did the double booking more than once, several times, and that was why I thought that would jeopardize my career, and something must be wrong with me, and I was afraid that I would be breaking down. So I was very much concerned. That was why I visited Professor Asada Takashi of Tsukuba University, and I visited his memory clinic, and Dr. Asada did the clinical testing, including a cognitive test as well as MRI for the brain imaging. And then I was told that I had suspected MCI, and that was a big shock for me. And I was very much distressed. But the doctor said that without the pharmacotherapy, the exercise could suppress the progression of the symptoms. That was why I still keep working as a part-time reporter, and I go to the memory clinic of Tsukuba University, the daycare center, once a week. And that was my experience, and it was the first experience for me. I draw the pictures, and I also use the instruments to play music together. That was music therapy, and also the real task and the cognition game and the cooking in order to train the memory. So all these different programs were aimed at stimulating the brain in order to slow down the progression of the dysfunctional brain. But at the initiation of the training, I saw many elderly persons, and they were ahead of me, and I burned myself during cooking, and I stepped on the female's feet while dancing. So I was very much embarrassed. But I met my fellow patients, and they encouraged me. It's okay, take it easy. Because you fail, that's exactly why you're here in this training session. So if you keep on training, there would be the path that would be opened for you for improvement. That was why I'm still going to the sessions. However, the improvement tempo is very gradual. It doesn't improve all of a sudden, but I feel that I can feel that I'm gradually being improved. Probably persons like myself. There are many, and there are many people who are afraid of becoming dementic. That was why I decided to speak up. And I decided to write my experience in the articles in the magazine. The title is I Will No Way Go Dementic. That's the title of my articles, the series of articles. Through these experiences, I thought of the importance of exchanges with my fellow patients. As I have mentioned, we train together, and these are my fellow patients, and they encouraged me, and I encouraged them. And I got a great deal of courage from them. But of course, they are dementic patients, and they do not want others to know that they have the dementic conditions. But I overcome that hurdle. I'm open. I'm out of the closet. And that is why I'm trying to crawl out of this condition of MCI. That is why I declare myself I'm the patient, and I write a series of articles. But as a patient group member, I have my fellow patients, dementic patients, and they tell me various things. But when I tell them that I'm a reporter, I'm writing articles in a magazine, and then they stop talking to me. They are reluctant to talk about their stories to me. However, as time goes by and many years, I go with them. And then they began to confide, and they began talking about their personal stories. So are the patients' families. And I thought that because of this sort of the exchange, we encourage each other, and that's the most important way of having improvements. And through my experience, I saw that firsthand. To understand correctly the dementia, and that's the most important thing for the society to achieve. And I learned that firsthand as a patient. 10 months have passed since I began this early intervention, early treatment. In dementia, if you intervene early enough and begin treatment early enough, we can stop the progression of the disease. And this is also what I learned firsthand as a patient. Without doing anything, in several years' time, the disease would progress and become the full-blown AD or Alzheimer's disease or full-blown dementia. That's what I heard. So I was lucky because I had the early diagnosis for early intervention. The SOS from the brain can be perceived by the patient themselves. They are the first ones to notice something is wrong with them. So if you suspect something's not right, go to the specialist for examination. We're waiting for the disease-modifying therapies. However, these do not exist now yet. That is why I'm going through the various rehabilitations and the trainings so that I can have my conditions stop progressing. So I have great hope for the research and the development to come. Thank you very much for letting me take this podium today. Thank you, Mr. Yamamoto, for the precious story.
Thank
you very much. We're moving to session 0, but we have a housekeeping announcement. At the collaboration room 1 and 2, the OECD review of healthcare quality starts. So for those who attending this session, please move to collaboration room 1 and 2 for OECD reviews of healthcare quality. Now, session 0 will be held here in this room, and also there's the streaming at the Sky Studios. There are still seats available at the Sky Studios, so if you wish to view this through the streaming, please enjoy that. Thank you very much for waiting. We are now starting session 0, the challenges of dementia from participating countries. The chair is the Dr. Kenji Toba from National Center for Geriatrics and the Gerontology, Japan, and also Dr. Christian Beringer from Federal Ministry of Health in Germany. We plan to have this session before lunch from 10 to 11:30.
Session 0. In this session, the program a little changed. Mr. Christian Beringer will present a paper after the Kenneth Earhart. So I'll present the opening address, and Christian Beringer chair the four sessions. So good morning. As for the session 0, it will be at the very beginning of all the discussion of two-day conference, and we expect this session to be the chance for all the attendees to share the consciousness that dementia is a huge problem in every country, and to share the background knowledge of healthcare systems and basic policies related to dementia. Most audiences are not necessarily familiar with systems and policies of other countries, like National Health Service of United Kingdom and long-term care insurance of Germany and Japan. And acquiring those understanding knowledge will be helpful for deeper discussion and better understanding throughout the following sessions. Let us share the common basic policies and analyze different systems among participant countries. So please, chair the first position.
Yeah, thank you very much. And thank you indeed, Japan, for organizing this very important conference. And thank you for having the honor to be co-chair of the first session this morning. We will go right into the discussion and the presentations. You have got the program before you. And I would like to introduce as first speaker Charles Alessi from the United Kingdom. He's a senior advisor on dementia for public health in the United Kingdom, a medical doctor, and we are watching you first presentation. You have the floor. Thank you.
Thank you, and thank you very much for inviting me here today. I'm going to spend a few minutes actually talking about the approach that we have adopted in Public Health England around risk reduction and why we have thought that dementia risk reduction is a public health policy, because indeed we do. We clearly, like everywhere else, have a substantial problem in terms of the number of people with dementia. We have a substantial problem in terms of the number of people expected to be suffering from this condition over the next few years. And the overall economic impact is not insignificant. So it's very, very clear this indeed is a public health issue for England. And really what we did is we started to think in terms of what we can do until the time comes when we have a cure, and thought that risk reduction is really the only way in which we could reduce the numbers, or potentially reduce the numbers, who are getting dementia, and more importantly, postpone the symptoms of dementia to the latter part of life, to mitigate the impact of this group of diseases. So to this end, we called a consensus conference in May of this year, in Blackfriars, hence the name, the Blackfriars Consensus, which really started to think and talk about dementia as being a non-communicable disease, i.e., that there were things we could and should do to tackle the risk factors which are associated with dementia. Things like smoking, physical activity, alcohol, and poor diet are significant factors. And trying to manage these better, and more importantly, trying to manage these earlier, could well make a significant difference to the number of people exhibiting symptoms and when they exhibit those symptoms. We know what the risk factors are. They're very, very similar to the risk factors for very many other chronic diseases and non-communicable diseases. So in many respects, the message is new in terms of what needs to happen, but perhaps the packaging is. And I think this is really quite important. So what are we doing? Well, over the next 18 months, we have a whole program of work, which we have just published last week, which is around turning evidence into action, opportunities to protect and improve the nation's health. Within this document, dementia is one of the major and key priorities. And what we're really trying to do is to focus our work in four main streams: public understanding and personalized tools, support for people at higher risk, understanding and action, and evidence and research. And I'll go through these very, very quickly. Public understanding and personalized tools is probably one of the most important things we can do, because we need to start to get people to appreciate that the actions of today can have a material impact upon what happens to you tomorrow. So if you look after yourself aged 40, the likelihood of you developing non-communicable diseases when you're 60 is reduced. We've been really very successful at increasing longevity in medicine over the last 60 or 70 years. But perhaps what we haven't been quite as successful is managing the number of symptoms that we get towards the ends of our lives. So anything which helps with that is really important. Hence, we have started to look to develop a new way for people aged 40 to 60 to reassess their health, and lots of public campaigns around this. Together with that, we're looking to developing a personalized diagnostic tool. The 20th century was all about evidence-based care. The 21st is more around personal medicine. Hence, personal messages are particularly important. In terms of support for people at higher risk, we are developing risk reduction into the care and support for predisposing conditions. And we're raising awareness that smoking and dementia, for example, are connected. And the more people think about this as being not possible, but real, the more likely it is that people will change their behaviors. We also have an enormous opportunity within the British health system, and that is that we have a unified single health system, which includes things like the health checks, which are offered to every individual aged 40 and above who doesn't have contact with health services. So we're building in dementia risk reduction into these policies. Further to that, we're really trying to get dementia risk reduction understood by the health professionals, because surprising as it may sound, the link between life factors and dementia isn't quite as well expressed by the health professionals as it could be. People still think of these conditions as being conditions which only affect people when they're old, and there's not an awful lot you can do before you get them. Well, perhaps we don't have a cure, yes, but certainly there are things you can do to mitigate symptomatology until the latter parts of your life. And for this reason, we're doing quite a bit around incorporating risk reduction in training materials and curricula for new health professionals. And finally, we're thinking in terms of how we can start to develop an evidence base around dementia risk reduction on a systematic basis, because sadly, there's not an awful lot which has been written and not an awful lot which has been researched around systematic approaches to doing this. Yes, there's lots written about doing a little bit of this and a little bit of that, but doing it systematically to populations is something we really need to address, and I would suggest need to address this quickly. So I just want to give a little example of a personalized tool. This is a prototype. We're just looking at trying to develop it. We're developing it with University College London, and it really is a tool to try to assist people, certainly aged 40 and above, or even earlier, understand that their behavior now and their parameters now can affect the rate at which their brain ages. And if I have to just show a little screenshot of what this concept is, and it's nothing more than a concept at this stage. We're certainly not going to implement it. It's not a screening tool or anything like that. What it is something which we hope will incorporate in our health messaging and our health systems. And basically what it does is look at some of the parameters which an individual can actually put into the tool, which will then allow you to express the cognitive abilities at a certain age. And clearly, if, say, one smoked, one gets a fundamentally different result to if one didn't. That's the only parameter that changed between the two. This is a prototype. This just is proof of concept to see whether we can actually deliver something like this. But the intention is for this to be delivered for people who wish to receive this information. I think we have an enormous opportunity, gentlemen and ladies, to actually get our thinking together in terms of doing this systematically. And I would suggest that this is something we all need to do, because until we have a cure, if there is something we can do to stop the years of misery at the end of life and compressing that to as short a time as possible, I think we really should do that, and we can do that. Thank you.
Thank you, Charles, for this really impressive approach to prevention and action you have taken in the United Kingdom. have a very tight program, and we don't have much time for discussion. Is there any question of understanding? I would like to take one question if there's anyone. Otherwise, we would go ahead with the program. Right, thank you. Then the next speaker is Yves Jeannette. He is Professor and Scientific Director of the Institute of Aging and the Canadian Institute of Health Research. Please.
Thank you, Dr. Berenger and Dr. Toby. It's a great honor to be here in Japan in this legacy event, very important one, on a very important aspect of the challenge. So, officials, dear colleagues, it is my pleasure to share with you on behalf of the Canadian government the way dementia is faced, the challenge of dementia is faced in Canada. Canada, just like UK we heard, has the same tendencies and figures, except at the level of the Canadian population, which is currently about 35 million people. And we, of course, see the same tendency in terms of doubling until 2031 of the number of cases of people with dementia, the cost as well. But one thing that is particularly acutely perceived in Canada is the fact that, of course, dementia affects women particularly, and the proportion is about 2 to 1. And this is a very important aspect that we try to integrate in our plan, in our research plan. The Canadian Institute of Health Research has invested over $200 million over the last 10 years, and I'll tell a little bit about this. Now, how is Canada organized? Canada is a country where there's a public health system. However, there is no such thing as a Canadian health system. There is, in fact, 13 health systems in Canada, because each province, each of the 10 provinces and the 3 territories in the north have their own health systems. So that the health system delivery and the and the dementia plan, or the Alzheimer and related disorder plan, is in fact a initiative and a prerogative of each of those 13 jurisdictions. At this point in time, there is a number, approximately half of all the jurisdiction, who have written, adopted, and starting to implement a dementia plan in each of these provinces. In fact, in session 1 later this morning, you will hear Professor Bergman from Quebec, who will present one of the most interesting dementia plan in Canada, which is really based on a community approach. Now, what is Canada doing in terms of a whole if we don't have the jurisdiction of health? Well, the Canadian government, the federal government, has the jurisdiction of the prevention and also of the research. And this is why, very recently, in fact, at the occasion of the Ottawa Legacy event in September, Minister Ambrose and Minister Wong, Minister of Health, Minister Ambrose and Minister Wong, Minister of Seniors, inaugurated and launched a national dementia research and prevention plan, something that is very much in line with what you just heard from Charles Alessi. This plan was first worked and based on the opinions and the needs expressed by stakeholders, and the Alzheimer's Society of Canada was very much involved in the preparation of this plan. However, the Women's Brain Health Initiative was also very much involved because of the importance of women in terms of people, of the number in the prevalence of dementia. The National Plan of Canada is organized around 4 priorities. The first one is research, and I will say a word. The second one is prevention, and it is meant at reducing risk and promoting well-being through healthy living. And I've put here the logo of the UK Dementia Friend program, which in fact is inspired by the Japanese, long time ago, dementia supporter program, just because we are going to implement such a program, a Canadian version, inspired by Japan, inspired by UK, in Canada. There is also an effort made by Health Canada and the Public Health Agency in Canada to understand the different neurological conditions in the population that can provoke and end up into dementia. And there are different support for caregivers provided from a financial point of view, from an organization point of view, as well as prevention from a public awareness point of view. On the research side, I will have the opportunity tomorrow to speak more about the research strategy of dementia in Canada, but the most important aspect is the Canadian Consortium on Neurodegeneration, and sorry for the typo, in aging. And this is a recently introduced grouping, collaborative effort, bringing together the most interesting and powerful researchers of Canada from care to cure, just in the sense that Professor Saxena said from the World Health Organization, first care, then maybe try to aim for a cure. This is also including a very important contribution of the Canadian longitudinal study on aging, which is following 50,000 individuals in their age, and this is where it is possible to predict and look at the natural evolution of the disease. But there's also other newly introduced initiative, including the Work and Health Initiative and the e-health initiative on the use of technology, IT, as well as on how to support caregivers and even those individuals with early dementia to pursue their work, as we heard from the journalist this morning. Finally, it is very important for us not only to have Canadians collaborate themselves, but to collaborate globally. And Canada is a proud member of the Joint Programming on Neurodegenerative Diseases. I see Dr. Amouyel here, the scientific director in Europe, working with USA, working with the National Science Foundation of China, and hopefully one day with Japan, as well as within the Global Action Against Dementia, led by UK for the time being. Just to finish, some of the programs that are on the prevention and support for caregivers. For instance, there are programs to enable active participation in the labor force and the community. There's also programs to help seniors to age in place, including programs with financial support for people who decide to do so. There are, in fact, very interesting public awareness program on combating elder abuse, and this is very important. If you think that early cognitive disorders makes people very fragile and susceptible to being fraud by their family, for instance, or by people who wants their money. So it's a very important aspect as well. So abuse here is not only physical, but also financial and social. And Canada is also supporting 900 communities to become age-friendly. And in fact, I'm very happy to see that Canada is one of the leading country in the age-friendly initiative, which is coordinated by WHO. Thank you so much, and I hope I will learn a lot. I was very impressed this morning, in fact, by page 3 in the Japan Time, where there was a full page on dementia-friendly communities, and this is an example of what will be inspiring for us. Thank you so much.
Thank you very much, Yves. Are there any questions? I think it's rather very interesting to see and how the programming of dementia initiatives and approaches is now underway in different countries, UK first, Canada now, as we heard. In France, there was the Plan Alzheimer a few years ago, and we are now very interested to hear what the state of things is there. Etienne Hirsch, the director of the French Institute for Neurosciences, Cognitive Sciences, Neurology and Psychiatry will talk about this to us. The floor is yours.
Thank you very much. I would like to thank the Japanese government and the local organizers for inviting me and allowing me to share with you the organization of care for patients suffering from Alzheimer's disease in our own country. As our chairman just indicated, the French system was conceptualized through the second plan on Alzheimer's disease that was covering the 2008-2012 period. And it was really during this period that the full system was organized to cover every city, every region in our country. This plan will be pursued now by a new plan that will cover the 2015-2019 period, and we will extend, in fact, this plan to all neurodegenerative disorders, and this is really a challenge, but we believe that having common system, common research between all these disorders which share commonalities will make big progress, not only for dementia, but for all other neurodegenerative disorders. So as in the other country, we have a very high proportion of the population suffering from dementia, about 1 million persons in our country, and this will double in 2030. So the French system, which is a public health system, is a 3-level organization of care for Alzheimer's disease. The first level is really in the city where the people are living. It is supported by the general practitioner, and this is really the first people in charge of the patient. The GPs are in charge of identification and screening of patients with very, very simple tools. And in fact, they orient the patient to level 2 for a much more complex investigation. The follow-up of the patient in the connection with the local network, and I will explain what this means, is done also by the general practitioner. The level 2 is a little bit more complex with the memory clinic or the specialists. These are mostly neurologists, geriatricians, and sometimes psychiatrists, but less so. The level 2 allows a confirmation of the diagnosis based on specialized neuropsychological investigation and neuroimaging technique, and we have developed very sophisticated tool to allow an accurate diagnosis. This is also where the therapeutic intervention is initiated, and this is slightly particular to our country because most major drug companies are marketing, in fact, the specialists and not the GPs for Alzheimer's disease. And this is an issue because the general practitioner field, they are not part of the system, and thus this has to be improved. This level 1 and level 2 rely on local care system for Alzheimer's disease with services at home, with physical therapist, homemaker, home cleaner, occupational therapist. There is also, if needed, the specific teams for Alzheimer's disease, including physical therapists, occupational therapists, nurses, and psychologists, who can go at home and organize the home of the patient and teach how to behave to the patient and their family. There is nurse cases at home and daycare structure as in other countries with transportation from and to home, but we have to confess that we need to have more rooms for the patients in this daycare structure. There is also a personalized financial help from the government for those patients. Sometimes more complex services needed, and we have special case manager. These are very often specialized nurses who are in fact trained for Alzheimer's disease. And we have Center for Autonomy and Integration of AD patients. This is a single window approach to help the patient and their family to organize, in fact, the healthcare. When the patient cannot stay at home, we have local institutions. These are medicalized institutions for elderly, often with a coordinator, a medical coordinator who is a GP with a specialization in geriatry or a specialization for Alzheimer's disease. And as I said, our French system is a national system. 1/3 of the cost is paid by Social Security. 1/3 is paid by the French National Funding Agency for Elderly and Handicap. And 1/3 is often paid by the family or a private insurance of the family. Sometimes the patient cannot stay in this very low-level medicalized institution, and they have to go to more specialized structure, to the hospital, and they are taken care of in cognitive and behavior unit for agitated patient or patient with behavioral disorders. They stay for a few weeks or a few months in this system, and they can go back to the medicalized institution. Or if the problem is very severe, they are transferred to long-term care unit for 80 patients in public hospitals, and they are taken care of there. After level 1 and level 2, we have the regional center, which are the more complex organization. These are a regional expert center with platform and resources for the complex diagnosis and patient with young onset Alzheimer's disease. This is where clinical research is developed, and a whole part of the previous and the new plan will cover clinical research. And this is where the clinical trials are, and especially the disease modifier treatment are studied. So this level 3 organization covers the whole country. This is France here. And you see that in each region you have this regional center, CMRR, which are the red dots. You have the memory centers, which are the green dots. This is the Paris area. France is a very centralized country with neurologists covering the whole country. I have not represented the GP because the country would be black. We have a relatively nice covering of this. This I would like just to mention was what Professor Florence Pasquier will discuss this afternoon, which is the Center for Young Patients. She is in Lille. She is organizing this network in the country, and you can see that we have local correspondent for the young patients with Alzheimer's disease, who needs a very specific care. So in summary, the 3-level organization of care for Alzheimer's disease in France allows a local care of the patient suffering from dementia. This allows patients to stay at home as long as possible, addresses the different stages of the disease, and allows a cost-efficient treatment. But we have to improve the system. The number of patients will increase in the coming years, and we have to double the structure. The GP needs to be better trained, and the system needs to be adapted for other neurodegenerative disorders for our new plan. Thank you very much.
Yeah, thank you very much for this picture of how European countries organizing the dementia policies, and also looking for new approaches and new ideas and developing the plan. And we are now going back, if there are no questions, understanding, to the American continent. And Kenneth Earhart will talk about the Alzheimer policies in the United States. He's from the U.S. Department of Health and Human Services. Kenneth, please.
Good morning. Minasan ohayou gozaimasu. I am Ken Earhart. I'm currently serving as the U.S. Health Attaché to China, and I'm here reporting on behalf of the Office of the Assistant Secretary for Planning and Evaluation. Thank you for the opportunity to share the U.S. National Plan, its challenges and progress. Oh, got it. This will be our take on a similar theme for the day. There are 5 million people in the U.S. With Alzheimer's disease and related dementia. And as you heard earlier, as our population ages, this number is likely to significantly increase. The cost in both direct and indirect costs is estimated at between $159 and $215 billion a year, as much or more than any other disease. Our national plan is designed to address these major challenges. While research is making steady progress, there's currently no way to prevent, treat, or cure ADRD. There's a need to continue to improve the quality of care and the training of care workers. The majority of people with ADRD live in the community where their families provide the bulk of care. They need support. The stigmas and misconceptions that impact care and isolate people with ADRD and their families needs to be addressed. And the significant efforts by both public and private sectors to address ADRD should be coordinated and tracked. Prior to our National Alzheimer Project Act, there was significant investment in research, clinical care, and long-term care. In 2010, over $500 million were spent on ADRD research, most through our National Institutes of Health. In 2011, taking immediate action, funding for research was supplemented by $50 million in 2012 and $40 million in 2013 to support new Alzheimer's research. The National Alzheimer's Project Act, enacted in 2011, creates an opportunity to focus the nation's attention on the challenges of Alzheimer's disease. Key features of this act include creating and maintaining an integrated national plan, coordinating research and services across federal agencies, accelerating the development of interventions, improving early diagnosis, improving outcomes for minority populations at risk, coordination with international bodies, and creating an advisory council to monitor the national plan. In addition to increased funding, early activities included formation of the Federal Agency Working Group and Advisory Council, formation of research, clinical care, and long-term service and support subcommittees, quarterly formal and ad hoc informal meetings of these groups, and a focus on improving current programs serving those with ADRD. The national plan is intended to balance work on new and future treatments with improving care needed now by people with ADRD and their families. It requires engagement by both public and private stakeholders. It involves immediate actions that are reviewed annually and strategies to achieve long-term goals. It must be implemented on a timeline and reported on transparently. It was most recently updated in April of this year. The goals of our national plan are to prevent and effectively treat Alzheimer's disease by 2025, to optimize care, quality, and efficiency, to expand supports for people with Alzheimer's disease and their families, to enhance public awareness, and to track progress and drive improvement. Some of the highlights of the progress made to date include recommendations developed on how best to advance research on Alzheimer's disease. Clear milestones for the national plan were established to achieve the 2025 goals. Resources were provided to train more than 10,000 healthcare providers. And resources have been made available online to the public. Recommendations were also developed for research on other related dementias. And just initiated this year is a national cognitive health awareness campaign, a multi-agency effort that involves both government and non-government stakeholders. The national plan is extensive and undergoing continuous review, and you should expect the next annual update in 2015. Lastly, in the next research summit to be held in February of 2015, it will be basically done to drive a set of updated recommendations and revised milestones that will guide subsequent investments in the subsequent years. Thank you.
Well, thank you very much for this overview, and also especially for the mentioning of the legacy event to be held in the United States in February next year. So I give over now to Kenji. I'll be go on with the program.
Yes, so I will chair the last 4 sessions. I move to the situation in Germany by Christian Berlinger, the Federal Minister of Health, Germany. Please.
Thank you very much for having the opportunity to talk very quickly about the German system, the challenges and fields of action we find in respect of dementia in Germany. And I try not to work with this. Right. As all the other speakers, I start with a few figures. And I think we, in every country, just struggling with the problem of dementia care and research, we find the same developments. We find a changing population structure, changing demographic situation, which is, you can see with a low birth rate and an increasing life expectancy. Increasing life expectancy is something which we find is a very good thing, but of course it brings a challenge to us. The whole demographic situation in Germany is, as you can see, that the population will decrease in the next decades, and the number and the share of elderly people will be rising at the same time. So in 2060, we expect to have a number of people over 64, well over a third of the population. And also this means that the number of people in need of care is going to increase. We have about 2.4, 2.5 million people in need of care as defined by the long-term care insurance system today, and this will nearly double in the next decades. And the number of people in need of care, not of physical but also of mental disorder reasons, people with dementia is also to rise. And so as we have now about 1.4, 1.5 million people with dementia, this will be rising to 2.2 in 2030 and about 3 million in 2060. These numbers, think about if there's no change in prevention, no change in medical treatment. The numbers we have mostly stem in Germany from the long-term care insurance system, and also the concepts and tasks and ideas of policy formulation are mostly grouped around the long-term care insurance system. But there are a number of different approaches we have to go. There is supporting and coordinating research efforts in diagnosis and therapy and in preventive measures. A new bill on prevention, health prevention, has been brought forward by the government only on Friday last week and is now being discussed with the other ministries and the Länder and also with the general public, and will be brought into Parliament later this year. What we always have to do is to improve our long-term care insurance scheme, and we have to focus it stronger on people with dementia. We have to develop in the care system, in the nursing system, instruments and therapies that are not only based on drugs. We have to focus on care at home because people, if you ask people and families, where do you want to receive your care, where do you want to care for people, most of them say we want to stay at home as long as we can, so we have to focus our policies on that. And the last and most important approach we have now in Germany developed is the National Alliance for People with Dementia. I will talk about this in a second. First, about the long-term care insurance system, which has been in force since the mid-1990s. It's a compulsory system for the entire population based on contributions, like the health insurance system we have for a very long time. And we have more than 2.5 million persons, not 2.5 million persons receiving benefits in cash or in kind, living in institutions or getting care by care services coming to one's home. The insurance only covers a share of the total cost for care, so people have and families have to have their own input for covering all the costs which are brought forward by dementia or care needs. And we are steadily reforming the system, of course. The Reform Acts in 2012 and 2014. We have now finishing of our parliamentary debates on the Reform Act in this week in the second chamber. They are trying to offer a more flexible approach to care, especially for people with dementia. We are opening up more and better approach to day care and night care opportunities. We are widening the approach for respite care and other things within the insurance system benefits. And we have a very long discussion now going on in Germany, which is very important with respect to people with dementia. When the system was designed in 1994, the need of care was defined as being need of care for physical reasons, because dementia was not on the agenda at that time. And we have to reform and formulate the definition of what does it mean to be in need of care. It does also it needs to encompass also dementia. So this is a very important step the insurance system has to go, and this will be the next Reform Act, which we are planning to table in the next year. The important approach, as I said, is to go to the families, because most of the people receiving benefits from the care system live at home. 1.4 million persons live at home. They receive family care. 80% of them receive family care, and 20% of them receive care by care services. So we have to design the system to enable the system to have individual approaches, to have a good counseling of families and people in need of care. We have to reform and strengthen relief measures for family carers. We have to support volunteer work, and we also have to look for new forms of accommodation, not only the two possibilities living in the care home or living in the family, but also living together with others in people in need of care in small units within the community on the local level. And this is one thing which is also strengthened by the Initiative for Local Alliances for People with Dementia, which we talked this afternoon about. And we are now in Germany since 2 years trying to bring all these ideas together in the Alliance for People with Dementia, which is part of the demographic strategy of the German government. The agenda, Joining Forces for People with Dementia, was signed in September. It has got 4 fields of action: science and research, social responsibility for people with dementia, support for people with dementia and their families, and also structuring the support of the health and long-term care systems to coordinate the help and to be able to offer better support from the social security system. A progress report on this agenda will be following up in the late 2016. Thank you.
Thank you for Ms. Chimbering. Is there some comment or question? Okay, so then we move to the next speaker, the situation in Italy, the Teresa Di Filandra, the Ministry of Health, Italy. So, Ms. Teresa, please.
Thank you. And thank you, everybody, for having invited me here to present the latest strategy of Italy in the field of dementia. First of all, just a little glance at the whole of Italy, because we share with other speakers some of the situation. The country is a very small one, but with a large population of almost 60 million people right now. And we share with Japan the life expectancy, which is very high. And it is also a little bit increased. Those data refer to 2012. But we share with Germany the low rate of total fertility. So we are really an aging country. And dementia is, for this reason, a very important and crucial issue in our country. For example, we have estimated to have around 1 million people with dementia right now, the majority of whom are affected by dementia, by Alzheimer's disease. And we estimate a number of 3 million people working around in an informal way, family and carers who are taking care of the people at home and working also in cooperation with professionals working in the field when officially taken care for in the national health system. Maybe you are aware that in Italy the health system is a public one, is an open access with the majority of services delivered completely free for the population. And we started affording the problem of dementia in a more structured way in the year 2000 when we started a project which is called Chronos. This is the Greek word for time. And so, because the dementia is a time-related and age-related disease. And we started an observational study on pharmaceuticals to give them on a free basis. And from that, we established a totally new approach to the problem, multiplying the services to be found in all over Italy, from the number that was available at the moment. There was around 50 specialized centers, let's say sort of memory clinics, to 500, over 500 services, which were regionally based, because, and this is another characteristic of Italy, we are a small country, as I said, but we have 20 regional authorities. This is almost like Canada, which are really independent as far as social, especially, but also health matters are concerned. So we have a framework of national laws, but we have all the services organized according to the regional and local needs. So in a survey that we did in 2006, we counted around 503 services, units or memory clinics, distributed according to the population of the regions. The numbers are inside the region. And we counted over 2,000 professionals working in the field of different kind of professionality, which means we had neurologists, geriatrists, nurses, psychologists, psychiatrists, and social workers. Today, we are updating our survey. The survey started before summer, and we will complete it, I hope, by the end of the year or at the beginning of the year. It's paid by the Ministry of Health and is run by the National Institute of Health, which is collecting information on the global offer of services in our country, taking into account all the regional differences I was mentioning before. Data will be the basis for monitoring the application of a new strategy that we just issued last month. So it's a very new one. And we rely on the fact that the crucial needs in the different 20 regions will be the basis for a real action on our territory, taking into account that at national level, we have to assure essential levels of quality of care which cannot be forgotten by our local administration. So each citizen has a right to have a certain level of quality of care and of free access to the services, even if the organization could be a little bit different in the different regions. So the new strategy that has been developed by the Ministry of Health, but in close cooperation with representatives from all the 20 regions, from the National Institute of Health, and this is something of which I am particularly proud, with the involvement from the very beginning of the Association of Patients and Carers, who have been there to say to us if what we were developing was really meeting their needs. The strategy globally addresses a few major points, which are the same that other speakers have underlined, and I think are the same that we share all over the world. And there's prevention, which is a new entry in a way, but is something that we are really considering as a crucial part of our work in this field. And we already have a national plan on aging. We have a program which is called Gaining Health, which approaches the prevention side of all the kind of disease that we can have, with a special focus on older people. Then the network of services. We know that not only health is involved in this disease, we know that the social part, but also the environmental part and everything like this, it's important for affording in a proper way the issue of dementia. So we are working a lot on the network of services. On integrated care, you cannot give nothing less than an integrated approach to the problem, then a focus on research, and this is also something we are taking care of in this new program. It's ethics and all the tools to be developed to empower patients and carers. Any single objective is accompanied by a number of actions that have to be developed at the local level. So I just very, very quickly listed the number of actions that the major actions that we are envisaging. The integration of disciplines and different professionals, the integration of health and social approach and functions in the world, the training of specialists, but in many settings to be put in the field together with the training with GPs and carers to have common languages and common tools, the developing and all the adjourning of guidelines and consensus documents under the framework or into the framework of our national plan for guidelines, to be sure that quality of care is continuous monitored, to promote empowerment of people with dementia, to fight stigma, which is still attached in some areas to the problem, and to offer support to carers involving them in any phase of the treatment process. And just to close and to be in my time, I just want to say, to add that this is the semester from July to the end of the year of the Italian presidency of the European Union, and we have put dementia as one of the priorities, so we are going to have a conference, a major conference in 10 days, let's say, is on November 14 in Rome. And we hope to give an overview of what's going on in Europe, what's going on in member states, but we also opened it to the cooperation of the envoy will be there. We will have a presentation from WHO, and so I think that we will try to start deepening the discussion and giving the same issue to the two next presidency to go on for the next year, 2015, to go on with attention to the dementia. Thank you.
Thank you, Teresa Youngblood. Do you any special question or comment this time? Okay. Then I'll move the next speaker, the Eugen Schäfflein. He comes, the delegate of the European Union, and he will talk about the whole situation of the EU. Eugen Schäfflein from European Commission, please.
Thank you very much. Good morning. Thank you for inviting me to give an overview of activities at European Union level on behalf of the European Commission. In my case, the figures that have been at the beginning of each other presentation will follow a little bit later, but they will follow. And I would like to first very briefly explain that the European Union is not in charge of organizing care and delivering health services because these are matters that fall under the responsibility of member states themselves. On the other hand, the European Union works with member states in order to support them in their activities. And one of the fields where such collaboration between member states at European level was seen as being useful is the field of dementia. This process in which we are working, in which we are meeting here on building global action on dementia shows the need for countries to work together on dementia. At European Union level, such work has started already in 2009. It's an initiative that had been developed under the French presidency of the European Union. And the outcome of that has been a document by the European Commission proposing a European initiative on Alzheimer's disease and other forms of dementia. Only on 16th of October, so very shortly ago, we have presented an implementation report about that strategy, which is available on our website. And the strategy had 4 priorities: early diagnosis of dementia and promoting well-being with age. Early diagnosis was turned into timely diagnosis over the progress of the work, better understanding dementia, best practices in care for people with dementia, and respecting the rights of people with dementia. So how have we implemented this strategy? There have been a number of instruments involved. One of them was a so-called joint action, a collaboration involving 19 European member states under the name of ALCOVE and the lead of France. Secondly, this has been a project which has been implemented under EU health policy. Secondly, in 2011, a broader initiative on aging has been launched as a European flagship activity under our Europe 2020 strategy for growth. So European Innovation Partnership Active and Healthy Aging. And then, of course, we had activities under our research framework program. Now I come to the epidemiological data, because the ALCOVE joint action made a new estimation based on best evidence available, and it reduced somewhat the estimation of the prevalence and of the rate of the incidence of dementia in the EU population, as you can see. And then the other outcomes of the ALCOVE joint action were toolkits, very practical concepts for addressing issues that were addressed in the groups of member states on timely diagnosis of dementia, on support systems for behavioral and psychological symptoms in dementia. And this has been a subject that had been added to the joint action over time, antipsychotics limitation in dementia. The European Innovation Partnership, Active and Healthy Aging, is another process. It's not a fixed group, but it's an initiative to mobilize actors with a focus on regions and municipalities. And 1,000 EU regions and municipalities are involved. And they work together to identify good practices and to scale them up when they have a potential for also helping other countries. And the objective is to increase the number of healthy life years by 2 by 2020. And the Innovation Partnership has 5 themes which is addressing, and 2 of them address dementia matters. One is on prevention of frailty and cognitive decline, and another one on innovation for age-friendly environments. Finally, there have been activities which have already been presented in June and then in Canada on research into dementia. I would also like to highlight that, so with an investment of more than 355 million euros between 2007 and 2013. I would also like to mention that e-health policy is very active because it's seen as having a great potential for improving prevention and also the care and quality of life of people with dementia. So far, 3 projects have been completed with support from the EU, but further ones are on the way. We have also developed close collaboration with the NGO Alzheimer Europe, support its operating costs and its annual conferences. As you can see, the implementation of the EU dementia strategy combined a variety of instruments, which include the promotion of the collaboration between member states, the mobilization of actors from the various relevant backgrounds in regions, the use of EU financial instruments, and the work with NGOs. What I would like to highlight as a conclusion is that dementia is clearly a challenge for the large countries, such as the G7 countries. 4 G7 countries are also EU member states. They have relatively large, generous resources and infrastructures to work on it, but dementia is also a challenge for the other smaller countries, and the EU has successfully raised awareness about dementia as a common challenge in these larger countries, and the smaller countries, and it has put in place a platform for common work between them. One outcome is that in 2009, only 1 EU member state, France, had a national action plan on dementia, but now it is 16 EU member states who have such a plan or are working on it. And then to close the outlook, the implementation of our strategy began with a joint action, the ALCOVE joint action under lead of France. We are now setting up a succeeding new joint action on dementia, and this one will be led by Scotland on behalf of the United Kingdom, and it will continue with the work on the of the issues addressed by the first joint action, but also address new ones. And the Italian, I'm very grateful for the support that the Italian presidency gives to dementia as an issue at EU context, and also for the conference as an opportunity to further develop the preparation of this next joint action on dementia. Thank you very much.
Thank you, Mr. Jürgen Schäfflein. Is there any question or comment? Okay, so we move the final speaker, the Tadayuki Mizutani, from Ministry of Health, Labor and Welfare, Japan. Mr. Mizutani, please.
Thank you very much, and hello everyone, and welcome to Japan. My name is Tadayuki Mizutani, the Director of the Office for Dementia and Elderly Disease Prevention in Japanese Ministry of Health, Labor and Welfare, or MHLW. I appreciate this opportunity to speak on dementia prevention and care in Japan on this legacy event. I have been in this position since July, so I'm just 4 months old. And before then, I was in the Health and Welfare Bureau for the Elderly in the Japanese Ministry of Health, Labor and Welfare more than 10 years ago. And at that time, we were mainly focusing on physical care. However, in these 10 years, dementia issue is recognized as a growing concern, and the situation around dementia has dramatically changed. Not only the physical care, but the dementia care must be regarded as the standard element of the elderly care, as well as majority of long-term care insurance users are diagnosed as dementia. Preservation of dignity should be the foundational principle of dementia care. Services must be prepared within daily activity range. Methodology of dementia care must be developed. Communities should be rearranged to support persons with dementia and their families. These are the words from the report of a study group released in 2003. In 2004, the Japanese government modified the Japanese terminology for dementia, and this is one of the symbolic moments in our history of dementia measures. We had been calling dementia as chihou in Japanese, which is a combination of Japanese words whose meanings are idiocy and stupidity. Now we use the word ninchisho, which means cognition disorder in Japanese. According to the population-based survey performed in 8 cities and towns examining more than 5,000 people over 65 years old, prevalence rate of dementia is estimated around 15%. As for the MCI, mild cognitive impairment, prevalence rate is estimated around 13%, so 1/4 of the elderly are either with dementia or MCI. Currently, people aged 65 and over are about 1/4 of the population. In 2025, elderly people will be about 30%, and in 2060, it will be around 40%. Now, 1/10 of people are aged 75 and over, and the ratio will be increasing up to 1/5 in 2025 and 1/4 in 2060. Japan is one of the fastest aging countries, and the ratio of persons with dementia or MCI is supposed to grow due to population aging. So in 2012, we launched so-called Orange Plan, the 5-year plan for promotion of dementia measures. The basic concept of this plan is to develop a standard dementia care pathway. In order for persons with dementia to keep living in the community, early diagnosis and intervention is most important. Proper coordination of medical care, long-term care, and living support are the key for living in the community. And even though we see acute exacerbations such as BPSD, behavioral or psychological symptoms of dementia, hospital care or institutional care should be temporary, and another setting of care coordination is supposed to be in place to meet him or her after dischargement. In Orange Plan, we set so many numerical targets in order to create the basis for medical care and long-term care services. Medical centers for dementia are supposed to provide specialized medical care on dementia. We have 280 designated hospitals and clinics, and 500 in 2017 is the target. Primary care doctors need to acquire more skills on dementia care practices. We have seminar program to train primary care doctors. What we call dementia support doctors take on the role of supporting primary care doctors in dementia care practice. We have another seminar program to train dementia support doctors. When persons with dementia have physical complications, hospital professionals have to take care of dementia as well as physical diseases. We have another seminar program to train in hospital professionals. As for long-term care services, we have 3-tier training programs. Care workers with more than 2 years of experience will take practitioner training to acquire basic principles, knowledge, and skills of dementia care. As a second tier, practice leader training is ready for those with more than 5 years of experience. To reach a dementia care leader who can plan dementia care practitioner training and is supposed to play a leadership role, more than 10 years of experience and another seminar program are required. These are the examples of how we are trying to promote quality and quantity of medical care and long-term care professionals in Orange Plan. In order to early diagnosis and intervention happen, we have introduced Initial Phase Intensive Support Team, or IPIST. First of all, persons suspected to be with dementia must be found through various community networks. Then a team consisted of medical care professionals and long-term care specialists visits the person and his or her family and make an assessment of his or her situation. After home visit, team conference is held in order to make a planning for proper coordination of medical care, long-term care, and living support so that persons with dementia can keep living in the community. IPISTs are supposed to closely collaborate with medical centers for dementia and primary care doctors. We introduced nationwide long-term care insurance system in 2000. Cities, towns, and villages take on insurance. Insured people are the elderly aged 65 and over, and those between 40 and 64. People who are certified to be in need of long-term care can receive services with basically 10% of co-insurance. Various kinds of services such as home visit long-term care, home visit nursing, outpatient day long-term care, short-stay services, group home for persons with dementia, facility services available. The total expenditure is furnished 50% through insurance premiums and 50% through public subsidies. Now we are aiming to create integrated community care system where housing, healthcare, long-term care, and living support services are provided in a community setting in an integrated manner. Since 1/4 of the elderly people are estimated to be either with dementia or on the borderline, how we can realize integrated community care system for dementia is the most challenging and important issue. Again, early diagnosis and intervention is most important, and medical care services and long-term care services should be coordinated systematically and should be provided seamlessly as the stages of dementia progress. We have been promoting dementia supporters training program so that people with proper knowledge and understanding on dementia can take supportive actions for persons with dementia and their families, not only in communities but in offices, in schools, and so forth. People of every generation, every occupation are becoming dementia supporters, and it's now 5.5 million. Ms. Sugawara will elaborate on this issue at Topic for Tomorrow. My 8-year-old daughter happened to read the textbook of Dementia Supporters Training Program for elementary school students, which I brought home. The other day, when she watched the TV program on dementia, she proudly told me, "I know there are roughly 2 types of dementia. All the brain is diseasing in one type, and the part of the brain has diseased in another." We believe raising awareness for all generations as a basis for the dementia-friendly community. Thank you very much for your attention.
Thank you, Ms. Dari. Any comment or questions? So we have 10 minutes for the question and discussion. Any question or comment to any speaker? If not, so the summarize by the closing comment by the Mr. Christian Bellinger, please.
Okay. Thank you very much. I think this was a very tight and intense program, and it's not easy to bring this together. But I think it was intended, looking at the program of the afternoon, this session was intended to have a sort of introduction and a broad given overview of the different approaches in different countries and indeed continents. European Commission was also taking part of how to deal with the challenges which are posed by dementia. And we had the aim to define somehow what to do, what policy areas we find, and we learned a lot about that. We had to hear where to do this in politics, in the family, in the professional system, and what are the responsibilities in different countries. And of course, there was very clear the different national approaches, but I will try to bring a few things together, which I think we all share in our thinking and formulation of policies towards dementia. The first is defining the areas of action, the second is the explaining of approaches, and the third is working within the structures. So if you define the areas of action, it was nearly everybody spoke about research, which is important, and also the understanding and the information about dementia in the general political area and in the general society is a topic, I think, in every country. And also, of course, which is we center today about is prevention and care. And I think it was very good to hear how a prevention program can be modeled. We had in the first presentation from the UK a very good impression of how this can be brought together. I think this was rather outstanding as far as prevention is concerned. So these are the main areas, although it has to do with information and with fighting stigmas, diagnostic questions at the early beginning of dementia, how to approach the system from the general practitioner's perspective. Explaining approaches, that means, I think what strikes me is that in many countries which have been presenting, or we learn that there have been since quite a number of years or decades people working on the problem of dementia. And what now is happening since the last years or 5-10 years is that there is a coordination of these efforts. And this is can be seen in the definition of plans, of Alzheimer plans or dementia plans, or other words which have been found for that, where collaboration, Canada talked about collaboration of different institutions, coordination. In the United States, we have a planning Alzheimer policies. We have in Germany the Alliance. In Italy, we speak about the integrated care approach. So this integration, I think, is a very important approach, and which is a thing we commonly share in all countries on the G7 level, and I think, of course, internationally, because then coordination becomes really important. Of course, working within structures, every country has got its own societal and political organization, the path dependency on what has been before. So, like Germany works very strongly within the insurance system, which gears our action and is now broadly widened. Others work in other directions. But what is very common is that every country looks at what can central government do and also what can be done on local level, because it has been seen and talked about to us how important the family and the local level is within the policy formulation according the dementia challenge. And also the interdependence between professional approaches and the non-professional approaches, how to bring this together, to bring support to the families and to bring information to the professional side is a very important thing. This all goes together into a sort of struggle to strengthen public awareness and to strengthen planning activities and possibilities within each country and also on the international level. And I think we have made a very good first step today, bringing together these different ideas which we share in a common theme, and we will discuss today and tomorrow. Thank you.
So I'd like to give you the final address. I'm concerning about only one point. We have almost same platform to fight against dementia. One point is the prevalence of dementia, 50% in Japan and 7% in the OECD. Is it come from the ethnic difference or the difference of the survey method of survey? It should be important challenges, because if the prevalence of dementia is the same as Japan, 50% prevalence is very serious, much serious for the European, United States and Canada. So I'm concerned, only one point. But anyway, to solve the problem in a dementia country, we have the same platform, but we need Noah's Ark made internationally. Thank you so much.
座長の先生方、ご発表いただきました7名の先生方、ありがとう。
Thank you very much for the chairpersons and 7 speakers. Now, we would like to propose to take 90 minutes break. All of you who are here, please find some places to take lunch. There are some housekeeping announcements. Those speakers who are speaking today or tomorrow, and all those concerned, could go to the 51st floor to have networking lunch together. Conference room 7 has poster presentations as well as some booths. And we are going to have free discussion presented by the poster creators. Auditorium and Sky Stadium. These are the two venues to have afternoon sessions in parallel. This venue is for session 1, prevention and care of dementia. In Sky Studio session 2, scientific aspect of dementia will be held. It's all free seating, so please make sure that you find your own seat. And if it's full house, please accept that. And regardless of the prior registration, you can go to either of the session. And please do not take the simultaneous interpretation receiver with you. Please place it at your seat. And this program venue is a part of this Roppongi Hills Club, so please do not eat or drink outside of these rooms. Finally, those from overseas who are going to want to participate in the tour to be held on the 7th of November, in front of the auditorium there is an information desk for you to approach. We'll resume the session from 1 o'clock in the afternoon.